So it seems fitting that Kim and I are up here today introducing our opening keynote, Dr. Peter Slavin, president of Massachusetts General Hospital, given that both of our careers launched there. Working at a world-renowned hospital are highlights of both of our young careers, but somehow we miss seeing Dr. Slavin talk during our time there. So today's truly an opportunity for us.
Massachusetts General Hospital has been ranked the #1 hospital in the nation in U.S. News & World Report's Best Hospitals for 2015-2016 based on quality of care, patient safety, and reputation. Dr. Peter Slavin has been the president of Mass General since 2003. He received his MD from Harvard Medical School and his MBA from Harvard Business School. He did his training in internal medicine at Mass General and was the senior vice president and chief medical officer. Today, Dr. Slavin will be discussing the challenges in healthcare delivery. It is our pleasure to welcome Dr. Peter Slavin to commence the day.
So just click this way.
So good morning, and I want to also congratulate the students for putting this conference together and seeing all the communications and emails that my office and I received over the last few months and weeks. This is obviously a very well-managed conference, and it's particularly impressive that students have pulled this all together. And I want to thank them for the honor of being invited to speak with you today. What I wanted to cover was some of the things going on in this country, in this community, and at Mass General about ways to make our healthcare system better and more sustainable. I personally am very proud that Massachusetts has played a leadership role in a number of important trends in healthcare over the last couple of centuries and within recent years. There's no doubt that if it weren't for mass health reform, the Affordable Care Act would not be in place. So we took a pioneering role in extending coverage to almost all of our citizens, and the federal government and the rest of the country has followed in our footsteps. As I'm going to mention, I think there's no question that Massachusetts is now trying to do the same thing for trying to bend the cost curve, and there are countless things going on in this state, in this marketplace, aimed at trying to improve care, but at the same time make it affordable and more economically sustainable for our country. And I think it's also fair to say that, that Boston, Massachusetts is the epicenter of the revolution in the life sciences that's going on within this world as well. If you were to draw a 5-mile circle around where we are today, there's more biomedical research going on within it than any other circle you could draw anywhere else in the world. It is what is happening in a variety of fields, and I'm going to touch upon one later, in terms of the research, is truly breathtaking. The research has never been more exciting. So I just wanted to start by highlighting why we do need to bend the cost curve in this country. And this is just some dates, some of which are near and dear to my heart. I graduated from college around 1980 when healthcare was about $200 billion in this country and about 7 to 8% of GDP. People back then thought that the sky was about to fall, that if healthcare grew anymore, the world would come to an end. But it didn't, and now we're up around 17 or 18% of GDP, with all estimates indicating that we're going to cross 20% because of the aging of our population. Certainly we're closer to the world coming to an end than we were back in 1980. And as I'll show you, I mean, healthcare expenditures are a significant problem for the budgets of individuals, families, governments, and businesses, and the current trends are simply not sustainable. This shows what's happened to the state budget in Massachusetts between FY01 and FY14. On the left is healthcare, which has taken up 37% more, or has grown 37% in absolute terms, from about $9 billion to over $15 billion. And you can see that every other category, mental health, public health, education, human services, housing, law and public safety, and local aid, has been cut dramatically. So healthcare is crowding out other public goods that our society needs, and we need to be sure that every dollar we're spending on healthcare is absolutely necessary. I tend to be a big fan of Apple, but I do like this quote by Bill Gates. He said, Politicians must address tough questions about limited resources. How many teachers are you willing to fire in order to have 78-year-olds have a procedure which will be invented 5 years from now that adds 4 months to their life? That sounds terrible, but infinitely choosing those things will shift you away from education for the young and towards infinite invention of such medical procedures. I do really think that we are facing those kinds of trade-offs in our society, and again, I think it's really important that we as people, managers in the healthcare industry, do what we can to try to improve care and make it more affordable. I certainly hope that as you pursue your careers that is what you will do. I have seen too many people, physicians, people with management degrees or both, look for opportunities to make the healthcare system maybe better, but less affordable for their own personal gain. And I certainly hope that you will try to do well by doing good for our society. In terms of where the money goes in our healthcare system, the biggest place is to hospitals. Physicians are the second biggest part of the pie. And then obviously there are lots of other things that consume healthcare services ranging from nursing homes, home health care, et cetera. We as a country certainly pay a lot in our country for the very complicated financing system that we have. We at MGH have to deal with about 200 different payers. The complexity involved in that is enormous. The cost involved in that is enormous. And that is one big difference in the healthcare costs in this country compared to others. If you look at why healthcare costs in this country are significantly higher than the rest of the world, I think there are a number of reasons. By far the biggest is that we use more technology than other countries. There are more cardiac surgical programs in LA County than there are in all of the country of Canada. We use MRIs and other expensive diagnostics much more frequently than other countries. Whether the care is better as a result of that, I think remains an open question, but that certainly is a trend in our healthcare system. Certainly one of the things that is driving costs up, probably about 1 or 2% a year, is the fact that our population is aging. Another thing that has driven costs up is the fee-for-service reimbursement system. And in this part of the country, that reimbursement system is dramatically declining. We have seen a massive shift in this market toward global payments. The notion being that if you give providers a fixed budget and have them take risk for a population of patients, that they might make decisions different than they otherwise would. Clinician salaries in the U.S. are higher than in other parts of the country, other parts of the world, although that gap has narrowed significantly. And then, as I mentioned before, administrative costs are enormously higher here in the U.S. compared to other parts of the world. One issue that has arisen both here in Boston but also around the country is why are teaching hospitals so expensive? Why on average are their prices 20 to 30% higher than community hospitals? And this was a study that was done back in 1998. Unfortunately, it still remains the best study on this subject, done by Lewin Group. But it looks at teaching hospital and community hospital costs and breaks them down into the costs that are actually related to the direct care in blue, costs related to the fact that teaching hospitals tends to be in cities and have higher case mixes, which are and so being in cities have to pay higher wages. So the wages and the case mix are in red. But then the green is the costs associated with the other missions of teaching hospitals that community hospitals simply don't have. Costs of supporting research, the costs of supporting education, the costs of having having standby capacity for things like level 1 trauma centers or transplant services, et cetera. And so as you can see, the direct costs of care, if you adjust for case mix and location, are roughly the same between teaching hospitals and community hospitals. What drives the difference are these public goods that teaching hospitals provide, namely education, research, and all these complicated services. So when you hear people saying we should shift care from teaching hospitals to community hospitals in order to save money, what they are really saying, based on this slide, is that we should cut our investment in research, education, and erode these standby services. That's because those are the things that are that make the costs higher. And this is just another slide which measures the magnitude of those different costs. I think another thing that people often people lose sight of when talking about the difference in cost between teaching hospitals and other hospitals is the economic benefit associated with teaching hospitals. I think if you were to interview people over in Kendall Square, which is probably the greatest concentration of biotech companies and research pharma laboratories in the world, probably the single biggest reason why they are located there is because they want to be next to MIT, they want to be across the river from Mass General, they want to be down the river from this university, the other Harvard teaching hospitals, et cetera. So there's no doubt that these institutions have had a huge stimulating factor on the economy. It was estimated by a study done by the Conference of Boston Teaching Hospitals that teaching hospitals have created are responsible in their own workforce for 72,000 jobs, which has a $13.5 billion impact on our local economy. And if you look at the jobs that are created indirectly, including those over in Kendall Square, there's another 57,000, so another multiplier effect of another 17 billion. So these institutions are more expensive than community hospitals, but for those additional costs, you're getting those public goods, and you're also getting many other benefits as well. So as I said, we have a higher mission and personnel-related costs. We're research powerhouses. The Boston hospitals dominate the list of the NIH list of most heavily supported research institutions. I think we are number one. The Brigham is number 2 in the country. We garner support from a number of benefactors who want to support biomedical research. We're training the future healthcare leaders, including 2 that introduced me. We're providing thousands of jobs, helping drive the economy, and we're, as you'll see, working hard to transform the healthcare environment. So now we want to transition to some of the work that we're focused on, trying to make care better and more affordable, and I want to share with you a couple of examples. I guess the most potent strategy to address bending the cost curve, I think, is without question population health management. How do we not take our eye off the needs of individual patients, but how do we focus our attention on a population of patients and try to figure out how we can manage that population in again, a very high quality, cost-effective way. I think to a larger degree that means tailoring, in a mass customization way, tailoring our care to the needs of each and every patient, which all of which are different. And there are many different ways to define populations. One is from a community perspective, the population of people who live here in Boston. We haven't been assigned by the government to be exclusively responsible for the care of all the people in the city of Boston. So from a provider standpoint, we look at populations in a number of different ways. We look at the population of our own employees. We look at the population of people who get their primary care through us or referral patients. So there are multiple ways for us through the lenses that we have to define various populations. Obviously, these things overlap and are synergistic, but defining who the population is an important part of the challenge. For many years, certainly for most of my career in healthcare, we have been focused on this innermost circle here, namely managing inpatient and outpatient encounters. The fee-for-service system pays hospitals, physicians for individual encounters, and our billing systems and our systems of care have become perfectly, I wouldn't say perfectly, have been largely designed to manage these individual patient care transactions. Unfortunately, that is not the best way to care for a patient population. We need to expand our aperture to focus on episodes of illness. How do you array a set of encounters, inpatient, outpatient, to deliver the best hip replacement possible and do it in an affordable way? Or how do you care for a patient with diabetes over the course of a year? How do you sequence these encounters in an episode of illness? And then if you look at, take an even broader aperture, you're focusing on population health. How do you care for not just for an individual episode of illness for an individual, but how do you care for an individual's entire health over the course of the year? And how do you care for thousands of individuals' care over the course of the year? Ultimately, it comes down to trying to figure out how to provide the inpatient and outpatient and other services that they need, but it is a totally different perspective on the world. The payment system in this region is moving dramatically towards something that is called global payments. We used to refer to it as capitation. That got a bad name in the 90s. So now we use a different euphemism called global payments, but it's essentially the same thing, where we get paid a fixed amount per person over the course of the year, and if our total healthcare budget comes in below that amount, then we split with the insurer the surplus, and if we come in above the budget, then we actually have to write a check to the insurer for part of the deficit. That obviously forces providers to take a population health management view of the world, and I think on balance is probably a better way to reimburse the healthcare system. At MGH, all of our employees for a number of years have been global payment patients because we're self-insured, and we now have probably hundreds of thousands of our primary care patients who are covered under global payment contracts. All of our Medicare patients are part of a Pioneer ACO, and if you're insured through Blue Cross, Tufts, and Harvard Pilgrim and get primary care at Mass General, you also are in a global payment contract, whether you know it or not. You probably don't know it. You think you signed up for HMO Blue or some PPO product, but little did you know that your insurer and providers have signed these side agreements, which have converted those into global payment contracts. And I think one challenge we face with global payment contracts is the fact that this is sort of a behind-the-scenes payment arrangement. It would be much better if the population at large knew about it and was fully supportive of it and willing to help work with providers to make it successful. So we are in the process of rolling out dozens of initiatives, not only at Mass General, but across Partners Healthcare, the healthcare system that we founded with the Brigham over 20 years ago. Some of them are focused on our primary care practices, like patient-centered medical homes and high-risk care management. We are investing mightily in mental health services because I think it is quite clear that not adequately addressing mental health issues like depression, anxiety drive healthcare costs up, and more importantly are bad for the individual affected by those disorders. We're also doing a lot of things in specialty care, active referral management, telemedicine visits, et cetera. I think one of the big mistakes that was made in the 90s was all the effort was focused on primary care under capitation. We're trying to get everyone in our healthcare system involved in trying to transform the healthcare system. We are also focused on the care continuum. Within Partners, we have rehab hospitals, we have nursing homes, long-term acute care facilities. Recently, we've gotten into the urgent care business. We have home care. And so how do we use those resources to meet the needs of our patients in a way that is economically affordable? We need patients to be engaged in this process. Before patients undergo certain procedures at Mass General, they are exposed to a shared decision-making program where they can learn more about the risks and benefits of the procedure they're about to undergo or considering undergoing, and also learn from the experience of other patients who've undergone it. And that, I think, is useful to patients, and more often than not, reduces the frequency of the utilization of high-cost procedures. And we also, behind the scenes, are building enormous infrastructure, a lot of data. There's an enormous amount of analytic work that has to go on in order to manage this undertaking. We got into this about 10 years ago when Population Health Management, the Affordable Care Act, was not even a twinkle in anyone's eye at that point. We decided at Mass General to sign up for a Medicare demonstration project that was focused on our sickest and most expensive primary care patients insured through the Medicare program. I'm sure you've all learned in your classes here that 10% of Medicare beneficiaries are responsible for 70% of Medicare costs. In the commercial population, the Pareto principle is not quite that extreme, but it still very much exists. And so this demonstration project was focused on the 10% of our Medicare, 10% of our primary care patients under the Medicare program who were the sickest and the most expensive. And this is a picture of one of those patients who was asked to bring in her medications to her doctor that day. And I take one medication a day. I have a hard time remembering to take it. If you're older and sicker, you can imagine the challenges of trying to manage this pharmacy. So we built around our primary care physicians and care managers a high-risk case management program that also involve things like substance abuse specialists, mental health workers, people who could help with financial issues, pharmacists who could help with med reconciliation, et cetera. And we also worked with community-based services as well to try to better coordinate the care of this population. These patients who were covered under this program were generally in the hospital 3 or 4 times a year. They were on 12 medicines on average. They were the ones that our primary care physicians always worried about when they went home at night, because they didn't really feel like they had the time or the resources to fully meet all of these patients' needs. What was remarkable to us over a 5-year period is that we were able to reduce hospitalization rates by 20%, reduce emergency department visits by 25%. Patients actually who were in the program lived longer than a control group. We actually saved the Medicare program 12.1% of costs compared to the control group. Since the program cost about 5% of Medicare expenditures, the net savings were 7%. And if you were to extrapolate that over the entire Medicare population, you would see Medicare expenditures reduced by 4%. Another way of thinking about it is for every dollar we spent on the program, we saved Medicare $2.65. And this is a study that I think it was RTI did of all these demonstration projects. We were the only one whose effectiveness didn't cross sort of the null hypothesis here. And so we were quite pleased with the results of this effort. And it gave us the courage, maybe the stupidity, to decide to do population health management on a much broader scale. This demonstration project involved about 3,000 patients. We, across partners, are now doing population health management on 500,000 patients. So some of the other things that we are doing as part of this effort are, for certain procedures, patients have to undergo appropriateness criteria to make sure that it is appropriate for them to undergo the procedure. This is something that the physicians do in front of a computer, and will get the appropriateness, immediate feedback about the appropriateness of the procedure for this patient with a green, yellow, or red light. Physicians can proceed with the procedure under any circumstances, but we sort of audit the results. There's also, as I said, shared decision-making, which is really more patient-focused, and we are increasingly trying to capture and analyze patient-reported outcome measures as well. So we're looking at the need for the procedure, informed consent, trying to manage this whole process in this patient journey. This is an example of this appropriateness process. This is a patient who a doc was thinking about, with a patient who had carotid disease, and based on the patient's clinical situation, doing a carotid endarterectomy, a surgical procedure, was graded yellow. Doing a stent was graded green, and medical therapy only was graded as red. And so this is a way to give the physicians real-time feedback based on the medical literature, based on criteria that they and their colleagues have developed as to which procedure or which approach to managing this patient with carotid disease is most appropriate. Again, physicians can recommend to their patients any one of these 3, but we think it's important for them to have that feedback. And we then track our appropriateness rates by procedure for bypass surgery, carotids, stenting, et cetera. We are also, in addition to looking at episodes of illness, doing a lot of work within the hospital on care redesign, trying to make the hospital itself more efficient by reducing length of stay, reducing unnecessary testing, et cetera. And another thing that we are doing is focusing on certain vulnerable populations where, again, the same principles of better care coordination can make a difference. I'm sure you're all aware that opioid use in this region has become a huge public health problem. More people dying in the Commonwealth of Massachusetts of opioid overdoses than car accidents, which I think is a pretty startling statistic. This is not only a big problem for the individuals suffering from this mental health disorder and their families and their communities, it is also a huge expense to our society. For every one overdose death in 2010, there were 15 admissions for substance use disorder treatment, 26 emergency department visits, 115 people who are dependent or abusing, and another 730 who are non-medical users of drugs. If you add up the medical costs associated with this and put aside all the heartache, grief that this causes, it's about $4 million in healthcare costs for every one opiate-related death. So this is a huge public health issue and a huge economic issue as well. The way we and others treated opiate overdoses up until recently was somebody would show up in an emergency room with an overdose. We would bail them out of that overdose, admit them to the hospital, and once they were medically stable, we would tell them, don't do that again. It's really bad for you. You really need to avoid using narcotics in the future. It's a little bit like treating people with diabetes who come in with diabetic coma, and once they wake up, not sending them home with insulin, but just telling them to watch what they eat and don't do that again. It is biologically makes no sense at all. It literally takes almost a year for somebody with an opiate addiction's brain to revert back to normal, and so not having a system of care in place to treat them medically and follow them longitudinally biologically makes no sense at all. Treatment for opiate addiction is as effective as the treatment for hypertension and other chronic medical diseases. The medical therapy is actually remarkably effective, and when added to it is a system of care that follows people longitudinally, it's even better still. So this just shows on this slide that people with opiate addictions are more expensive to care for in the hospital. 29% of the patients in our high-risk program have a substance use disorder of some sort. At Mass General, we have about 30 to 40 patients a day who require individual sitters because they might hurt themselves or hurt a member of the hospital staff. We often have people who return to the emergency room repeatedly, and given the emergency department congestion that we and others face, this is an unnecessary problem that we're facing. And on any given day, I believe, on any given day at Mass General, about 3 to 4 nurses are assaulted by patients, many of whom have substance use disorders. So this is a huge issue from a healthcare employee safety standpoint as well. So what we now have in place at Mass General is not the system of care that I described earlier, but a new system where patients admitted to the hospital with substance use disorders are followed by not only their regular team, but by an addiction consult team made up of addiction experts. We then have a system of care to get these patients plugged into outpatient services, and frankly, there aren't enough outpatient services in this region or the rest of the country. And so to deal with that, we have a bridge clinic, which follows people between this vulnerable time, between them being discharged and finally getting into some chronic outpatient care. And then we've hired a number of recovery coaches. These are people who used to suffer, or I should say are currently successfully dealing with their substance use disorder and are coaching these patients about their own experience and helping follow them longitudinally. And these folks have made a huge difference in the lives of those currently traversing this system. Another thing that we've been focused on at Mass General is healthcare equity. We were the first hospital in the country to routinely capture demographic data in sufficient detail about our patients so that we could stratify it by race and ethnicity pretty reliably. And that enabled us in turn to stratify all of our quality data by race and ethnicity. And on our website, and we were the first hospital to put this on our website, is how we're doing on a variety of quality metrics if you're white or if you're non-white. And I guess one thing that is pleasing, at least for me to see, is that all of the lights here are green. So we have seen instances where we find problems where there's not green, where there is a disparity, and we put in place programs not too dissimilar to what I described for the substance use disorder patients, navigators, healthcare coaches, to try to reduce and eliminate those disparities, and we've been successful in doing that for colon cancer screening and diabetes management as well. been a lot of research going on in academic medicine measuring disparities. Unfortunately, very little effort at actually trying to fix them. So that's something that we've been very focused on. And this is an example where we found in 2005 that colorectal cancer screening rates among Latino patients was 35%, among white patients was 45%, so about a 10% difference. And after this program, both cohorts actually got better. And now if anybody's suffering a disparity, it's the white patients, not the Latino ones. So, we've seen pretty consistently that when we put in place a program to address an issue like this, everybody does better, not just the patients who are targeted. And then the final area I just wanted to comment on that I think is amazingly exciting, and I think that Boston is the epicenter of, is the biologic revolution that's going on in healthcare that will certainly make our lives better. I don't know if it'll make it more affordable. I guess it seems to me we need to get rid of all the other fat in the system so that we can afford these revolutionary things that are coming out of research laboratories. But we are proud of the fact that we were the place that published studies showing that you could treat people with targeted therapies with stage 4 lung cancer who had a certain mutation, an EML4 ALK mutation in their tumor, or somebody with a melanoma who had a BRAF mutation, or somebody with lung cancer who had an EGFR mutation. It's quite clear that a lot of cancers are caused by mutations in certain genes, and that if you have drugs that treat the sort of the product of those genes, that you can really sort of melt these cancers away, certainly temporarily, and hopefully with new advances for an even longer period of time. So now when I was a student and somebody came in with lung cancer, we would look at the X-ray, a pathologist would look at the tissue under a microscope, and based on how it looked under the microscope, we would categorize the lung tumor. Now all tumors, lung cancer and others, are subject to or undergo genetic analysis, and the treatment to a large degree is based more on the genetic mutations that are identified than what the tumor looks like under the microscope. So somebody with a lung cancer, depending on the genetic analysis, could get treated with a certain drug for KRAS mutation, an EGFR mutation, or an ALK mutation. So cancer care is being revolutionized, and I think Boston is playing a leading role in helping do that. This is a story of a 65-year-old retired lawyer with advanced melanoma, which used to be a death sentence. He was given 6 months to live. He enrolled in a phase 1 trial at our hospital, and within about weeks, simply by taking a targeted therapy pill, his tumors disappeared, and 9 months later he was able to do snow blowing. Hopefully he won't have to do that again this winter. We'll see. And the other revolution that is now being added to the one in targeted therapies is immunotherapy for cancer. Patients, it's quite clear that one of the ways that tumors survive is that they're able to turn off the immune system and prevent the immune system from killing them. Well, the biology of that has now been sufficiently understood that drugs have been developed to basically interfere with the tumor's ability to do that. And in about 75% of people with stage 4 melanoma who are treated with these checkpoint drug inhibitors, they seem to be cured. It is truly miraculous. And again, it's expensive, and it makes it all the more important that we get rid of all the other sort of waste in our healthcare system. So I wanted to close there by just saying that first, appreciate the opportunity to speak with you. Hope been able to show you that there is truly a revolution going on in our healthcare system to better tailor care to both from a management and organizational standpoint as well as a biologic standpoint to the needs of each and every patient, and hopefully the outcome of that is that patients will receive better care and our society will be able to afford that better care long into the future. So I want to thank you for your attention. I'd be happy to answer any questions you have. Thank you.
Sorry for sneezing on everyone. I hope that woke you up. We're going to open it up for questions now. So Cassandra and Shri are going to bring microphones up and down the aisle. So just raise your hand. We'll try to get to as many as we can.
Morning, doctor. I'm an MHA student at Suffolk University, and yesterday I was in the ACHE conference of Massachusetts. And one of the discussions was about what keeps CEOs up at night. And it's been really discussed about how the CVS Minute Clinic is going up, which is increasing access to healthcare. My question to you is, how does Mass General find CVS Minute Clinics? Are they competitors, or do you find them as partners in increasing better quality in healthcare?
Be a little bit careful about what I'll say, because my residency classmate Troy Brennan is the chief medical officer of Minute Clinic, and Andy chief medical officer of CVS, and Andy Sussman, who I think is speaking later on, was a friend of mine who used to work at the Brigham. He oversees the Minute Clinics. As I said before, healthcare costs are driven by sick people, not by well people. So I think that Minute Clinics can provide more convenient care to well people, but I think they're going to have a trivial impact on overall healthcare costs. In fact, I think as much as they may divert care from more expensive emergency departments, they will induce care that people otherwise wouldn't have gotten. But if you look at the commercial population, in any given year, 50% of people use no medical care at all. I think Minute Clinics, urgent care centers are a perfect formula for those 50% of people who use no health care to get more health care than they may need and drive costs up. So we are working with them. We've just recently opened a Minute Clinic not a Minute Clinic, but an urgent care center of our own in Brookline and Coolidge Corner. We're going to open up a few more. It probably is a way to help with primary care access, which is limited, but I don't think it's going to have a huge impact on I think it's going to have an insignificant impact on the major healthcare issues facing our society.
Hi, Doctor. Can you talk about how prepared and what hospitals are doing to prepare for global payment financial impacts to the system?
I think everyone is scrambling to try to figure out how to do this. We are investing mightily, tens of millions of dollars in infrastructure to do this. That infrastructure takes the form of case managers who are managing these high-risk patients. It takes the form of more psychiatrists, social workers to help with mental health issues. It takes the form of pharmacists helping patients on a lot of meds with med reconciliation. And it takes the form of analysts who are analyzing all this data from our own data systems and from insurers. So I think providers are scrambling to get the infrastructure in place so that you can manage populations intelligently. There are certainly companies out there like Optum that are selling those sorts of services to providers as well. So a whole industry has been spawned to help people do this.
Hello, Jane Oliver, Crows Oliver Group. To what extent do you think patients are prepared to be engaged? We talk a lot about, internally, we talk about patient engagement. What are you doing to ensure that they can be engaged and active participants? And what do you think we need to do as an industry to spur that forward?
I think patients want to be engaged to a certain degree. I think they want to know more about their healthcare issues. They want to be better educated. They want to know more about the quality of the healthcare providers that they're considering being cared for. But I don't think they want to be told what hospital to go to or what physician they can see, or they don't want to be told they can't have that MRI for the knee they sprained yesterday in a soccer game. So I think people are interested in being better informed, but I don't think at this point in time people are that interested in having the healthcare system constrain their choices. And so we're doing as much as we can in that environment. There's plenty you can do even if you're not actively constraining choices by better coordination, et cetera. But I think the American public is only partial. I think from a macro level, they're fully supportive of it. Everyone says healthcare costs are too high in this country, but when you ask the American public would they spend more on their own healthcare if it made a difference in their life and or the lives of a family member, almost everyone also says yes. So I think people are really conflicted and only partially engaged in trying to drive costs down.
And shared decision-making?
I think that helps because I think people benefit from, are educated about what the benefits of a bypass operation or a prostatectomy are, and I think that is very helpful and generally reduces the utilization of those services. But there's a lot of unnecessary care that is delivered in the healthcare system, and I think a lot of it, some of it is driven by what patients want. I mean, when patients, this is a trivial example, want to go to see a doctor with a cough or sinus infection, most don't like walking away without a prescription for something. And so I think a lot of doctors give prescriptions for something, even though the vast majority of those are due to viral infections, and the prescription does absolutely no good. When you say medical legal partnerships, I'm not sure exactly what you mean.
So I guess it's a new model where if there's a relationship between, I guess, for underprivileged populations where people can come in with recurrent healthcare problems, but they see that there's a bigger issue regarding the legal aspect. So if you have a patient who's coming in with recurrent asthma problems,
I see.
but where they're living, say, has asbestos or other things that are causing these recurrent health problems, I'm just wondering if you see that medical legal partnership.
Yes, no, we think those things are very helpful. In fact, we're doing that in some of our health centers where we have lawyers who actually volunteer their time to help patients suffering from asthma who, due to the environment in which they're living, and trying to use the legal system to get landlords to do something about that. So I think those sorts of things could be very, very helpful.
Maxim Shainin from Trinity Partners. Doctor, when you were answering the question from one of the previous speakers, you were saying that probably patients today are not very receptive to, this cost-effectiveness analysis, if you will, and these types of discussions. I was wondering what your personal opinion is on the use of cost-effectiveness metrics in healthcare, and do you think will the society change going forward?
I mean, having grown up as at least briefly, as a health services researcher, I believe very much in it. I unfortunately think there's a segment of our society that isn't interested in it and has tamped it down very dramatically. I mean, if you look what happened, we used to have an Office of Technology Assessment as part of the federal government that used to do very sophisticated technology assessments on various healthcare issues. That was abolished. If you look at the Affordable Care Act, it calls for the establishment of certain groups that will sort of do cost-effectiveness analyses, but it also says very clearly that Medicare can't use the results of those in its payment policies. So we are definitely underutilizing the science that could help guide us as to how to allocate our resources most wisely. So I think that's unfortunate.
Hi, I'm a student here, and also I work for CMS, and I just had a question about the Pioneer ACOs.
Yes.
Sounds like MGH has had success, but we hear a lot of conflicting reviews nationally. Just interested in how you think it's going nationally with the implementation.
We need to figure out how to make it work. There are some problems with the Pioneer ACO program, and there are problems with all of these ACO programs, and that we're sort of being asked to drive our car by looking through the rearview mirror. We don't know how we're doing until 6-12 months after the fact, and it'd be nice if we had more real-time information to guide us. And one of the challenges with the Pioneer ACO is that the goal line that you're shooting for is not clear. Our performance is being compared to other Pioneer organizations, or I guess Medicare expenditures across the country in general, and so it's not clear where the goalposts are, and they move for a variety of different reasons. So I understand that there are new forms of ACOs that are being issued by Medicare. I can't remember the name of one I heard about recently, where the goalpost is more fixed in advance, and so that may be a better way to go. We've been in the Pioneer ACO program from the beginning. We're still in it, but we are certainly looking at other alternative ACO models, and also looking at whether Medicare Advantage, becoming an insurer of our own, would make even more sense for our organization.
All right, that's actually all we have for time for questions.
Right.
Thank you so much.
Thank you.